I do want to mention one thing. All of the opinions expressed in this podcast are our own and do not reflect the opinions of the organizations for which we work or the recovery community at large.
No, not even close. Yeah, I would actually save that and play that at the beginning. I like that.
All right.
I like that.
That works for me. A couple of women got up and talked about partners, and I don't know how you feel, Dennis, but I found the presentation to be lacking, to say the least, and I think it was a missed opportunity.
Explosion.
Hey, this is Richard Zombeck, and you're listening to Buds with Suds. I want to remind everyone to please go ahead and subscribe to the show, and you can do that on iTunes, Google, Spotify, YouTube, and Stitcher. And if you could leave us a rating, that would be great too. Also, if you'd like to leave us a voicemail and we'll play it on the show, answer your questions, and comment on your comments, you can do that at 978-219-9554. In this episode, I talked to one of the show's buds, Dennis Doris, about Governor Baker's Recovery Coach Commission and the MOAR Public Policy Forum. It was the 16th annual Public Policy Forum by MOAR. Incidentally, in an upcoming episode, I'll also be talking to Jared Owen, who is the Director of Public Policy at MOAR. And on that note, here's the show. Okay, welcome, Dennis Doris, to Buds with Suds.
Thank you.
We did a roundtable together. I think that was episode 4 or 5. Today, Dennis is on to talk about. We were both at 2 different events together. We were at the Governor Charlie Baker's Recovery Coach Commission early last week, and the week before that, we were at the MOAR event for their public policy event. And I'm going to have Jared Owen on the show. I did an interview with him and talking a little bit about public policy and some of the legislation that they're looking at and things like that. But a couple of the things that Dennis and I are going to talk about on this episode is what happened, what they talked about at the Recovery Coach Commission. You can find that online with at mass.gov. And just look for the Recovery Coach Commission. Members of the commission are people like Mary Lou Setters, who's the Health of Human Services, Monica Barrell, who is with the Department of Public Health, Adam Stoller is with Mass Health, Carol Fiola is a state representative, and we've also got Cheryl, is it Olshan?
I think it's Olshan.
Olshan, yes. Massachusetts Association of Health Plans. Sue Ping Chin with the Gavin Foundation, and Dr. Kenneth Duckworth, who has a cameo appearance in today's podcast. We've got a recording of him. He's with Blue Cross Blue Shield of Massachusetts. There's a whole bunch of people, along with Haner Hernandez, who's a Behavioral Health Workforce Leadership Development Institute.
The good doctor.
The good doctor. He always says he's got Haner Hernandez Bonilla has more letters behind his name than he has in his name. He always introduces himself that way. There was also a new guy who's a new recovery coach that's sitting on the panel, along with Kim. She's
Kim Krosick.
And she's with MOAR, which
she's
is
a supervisor, yes,
Massachusetts Organization for Addiction Recovery. And again, we're going to have I'm going to have Jared on the show and in an upcoming episode. So, how this went at the commission was Mary Lou Setters made an announcement. I'm also going to have the entire audio. It'll be posted on the website underneath this episode. Mary Lou Setters opened the commission with basically what the commission was there for. I think she announced that I was recording it, and then they had 2 sets of panels. The first set was recovery coaches, and the second set was employers. So I think there were not recovery coaches, people who were using recovery coaches.
Yes, there were consumers and employers.
Okay. Well, good. You've got it broken. You should do this show. And the consumers, there were 3 people on there, so we'll hear a little bit from them, and also the employers. Among the employers were Chuck Weinstein, also
Kim Hanton,
Kim Hanton, who is
North Suffolk.
North Suffolk.
Danny Ginnivan.
Danny Ginnivan, who is with Elliott. Chuck Weinstein, who is with Partners, and Keith Scott, who is with. We still haven't figured that out.
Not sure.
He had a lot to say, though. He was pretty interesting. What kind of takeaways did you get from that commission?
So they also had that data thing at the beginning. Remember that from NMA or whatever it was, where they had that study where they were kind of tracking.
Oh, the rise?
No, it wasn't Rise. This was at the last one. Before the consumers got on, they had two women get up there from NMA or DMA. I think it was DMA, actually.
I thought they were with BSAS.
No, Julia was also supposed to be part of that. They were doing the data gathering for BSAS, I believe. So I think they were like an outside agency doing some kind of study, and that they were gathering data that was only BSAS data about recovery coaches, where they were, kind of what's working, what's not working, that type of stuff. And it was up until, I think it was a 1-year study up until 2018 or something, or 2017, I forget, but it was.
Yeah, and I kind of found what they were talking about didn't seem to make, at least to me, it didn't seem to make a lot of sense, because they were saying that they were only able to get data from certain points of research.
It was only BSAS that they could get the data from. So that, and I know that right now there's so much going on outside of BSAS. I think it was Hania who posed the question to them about something about tracking, and they said we can't. They said basically they cannot track what's going on, really. That was their response to his question, and that kind of stuck out to me. But so, despite all that data they gave, there's still a whole bunch of stuff they didn't gather. That.
So basically, what's going on is they're BSAS certified recovery coaches, or trained by BSAS, right? That they can, to a degree, track.
Yeah, that's who they can basically track, are people that are certified or are working in settings that are BSAS funded.
Right.
That type of stuff.
Okay.
That's the stuff they were tracking, and I think they sent out almost like surveys to recoveries, coaches, supervisors of those places, those programs that. So
anyone because I think RCA and the one down in Connecticut too will let CCAR will let you do classes out of your garage if you want, right?
Yeah, and yes, anybody can go down there and become a trainer. They can take the train the trainer, and then from there you come up here and you can train whoever you want. There doesn't have to be any, and that's one of the things we've been talking about, is that they can come up here and go, oh, you got money, I'll train. There's no set standard for them when they come back up here. Nobody's really tracking what they're doing or who they're training, and then where the people they train go from there. You could also become a supervisor, and sign off on these people's hours now, outside of BSAS. So by the time it gets to MBS ACC, and you got everything all buttoned up, and you got all your trainings done, they don't know. There's no way for them to track. So the poor woman who's doing these certifications just gets you. All right, you did your trainings. You did. All right,
you're signed off by a certified supervisor.
So when I say that, what I say, that's what I mean. It's not that hard to get, the secondary training system that we have. I'd imagine at some point, because it didn't seem like it was like that when we were kind of getting trained. It didn't seem like there were all these secondary training sources outside of BSAS. So I know BSAS was having trouble funding, as far as keeping up with the demand. So people were not able to get, say, cultural competencies, because it was only offered, say, twice a year. So it would fill up once it was offered.
Yeah, in Springfield or something.
So yeah, it would that part of it, they weren't funded enough to keep up with the amount of trainings that people needed. So I don't know if that played a part in this kind of, black market, if you will, of.
Yeah, really. It's kind of like this underground recovery coach training.
So if you look at it in a business way, right? The supply and the demand, that part of it, the demand was so high that the secondary, and now we have a bunch of Chinese knockoffs running around. That's what happened. That's how I look. I'm because They are. You got people going down there taking advantage of this situation, going, I can go down there and get trained. I can be a supervisor. I can train whoever. I can. And you got $600. I'll train you. And from there, people are going off and thinking they're coaches, and they're not supervised. They're not. So that's the whole. And I don't know how you get that horse back in the barn if they can't track anybody. So other than doing licensure or something like that.
Well, or even the CARC, right? I mean, you definitely have a repository of who is certified.
Yes.
Right? So, people who are hiring can definitely check that against BSAS's list of, I think there were now 70, right? Maybe it's up to 80.
I think it was upwards of 80. So when they gave that study, it was 70 something, but then Hernandez said an updated number was, yes, it was closer to 80
and it was something like 1,200 people have gone through the training, and 80 are certified, and there's something like 200 or 300 recovery coach supervisors, and they were saying something else too, that it was really hard to find supervision, right? Wasn't that another one?
Which if you look at those numbers,
it doesn't make any sense.
But
you've only got,
but and I know there's people that need certification. I mean, supervision aren't just certified. So that number 80 isn't just obviously the amount of coaches that are working. So there's a bunch of coaches that are working that aren't certified that need supervision. So
and that's part of that other number of people who are saying basically they went through the training and now they're certified.
Yeah,
but they're not actually certified. Actually, I've got a clip from Julia when she spoke at the MOAR event, and so let's listen to that, and then we'll talk about it on the other side.
And we now have trained almost 1,200 people in Recovery Coach Academy. Now, what that means is that we've trained 1,200 people to take a 5-day Recovery Coach Academy training. That does not mean we've trained 1,200 recovery coaches. You understand the difference? People who got a 5-day certificate were trained in recovery coaching. What makes you a recovery coach is that you are working or volunteering in a structured environment with a recovery coach supervisor supervising you, and that supervisor hopefully has taken the training from BSAS on how to be a recovery coach supervisor.
Yeah, so that was Julia
Ojeda,
and she's with BSAS.
She's the Director of Recovery Services, I believe,
right.
BSAS.
That was actually, I think, probably the most vocal I've ever heard her.
So I was going to say, so I'm kind of, before we got on here, I wish she would speak like that more often. And I understand because of her position, she probably can't be so opinionated maybe in public. And I respect that. But yes, that was good in that setting for her to speak. I've heard her speak similarly, but not too often. And that's, I think people need to hear that more often, especially. But the thing I don't agree with, maybe a little bit, not agree with, but I think CCAR, and by default BSAS now, because they've adopted CCAR's curriculum, they put more of an emphasis on the training. So I think CCAR kind of looks at it, whereas in kind of like as long as you're trained properly and supervised, like you can be a good coach, or you can be a coach. And I don't necessarily think that. I think we would, not to sound corny, but I think we were trained before we became coaches. Like our lived experience to me carries more weight than the training, I believe. That's my, so I don't think you can make, even though we take ethics and you can't teach somebody a moral compass. You can't teach somebody boundaries. You bring that into the role.
Right.
Whether you can only teach somebody so much.
Right. But the thing is that so what I've looked at the certification process as one particular thing, right? It absolves many places of people have been vetted, basically, right? Yes. You've gone through this class. I completely agree with you, right?
I'm not saying we shouldn't take the training.
No, I know. But what I'm saying is that I think the training is it's like any other type of training, right? We need proof that we've told you this, so that when you don't do it, we have recourse.
CYA,
right? It's exactly what it is, right?
Yeah.
And the the problem and the frustration that I think that Julia had in at least that clip was there are a lot of people out there that are calling themselves recovery coaches.
Yes.
And they're not, right? It's just, it's basically this kind of free-for-all right now.
Yeah, and there are also people taking the training that have no intention of, or no business being coaches, or intention of being coaches. They're taking it to learn the skills, or learn how to deal with recovery coaches, and that, to me, I think they should develop some sort of. We see police now. So the woman from Pari got up there and she talked about how they train police officers, and to me that's a huge. I don't understand where that is going, but I don't think they should be certified. That's fine, but she would pose it to you that they're teaching them these skills so they can better deal with people with substance use disorder, and that's fine. But now they think they're recovery coaches, and because now they took these trainings, and they're not. And I think they should develop some kind of training around other occupations, other disciplines that are going to be working alongside us. So,
compassion would be a good one.
Yeah, compassion, and that's what I mean. Like, so you're trying to give these people that, and that's. I don't know why they don't do. So they have mental health first aid, right? And that's how they teach people to kind of deal with a mental health situation. Why not? Because that's essentially what they're doing with people like the police officers. They're teaching these police officers how to deal with drug addict, substance use, people with substance use disorder when they come into a crisis situation. And that's not what recovery coach training is, and that's, to me, that's a problem. They should develop, I think we're smart enough and far enough along where we can develop some kind of training to help other occupations that are going to be interacting with recovery coaches, how to do it without teaching them how to be recovery coaches.
Right. But I did the supervision training, and I heard a lot of people that were at the supervision training saying that they felt that once they had done that, some people had said once they had done the supervision training, they went back to RCA and CCAR and did the recovery coach training, and it really kind of opened their eyes as to what they were supervising. Right?
Yes, I've heard that.
So to a certain degree, that may be correct, but also I think this is going to take a fundamental change. I attended a meeting where I work with the COO of the organization and a whole bunch of leaders in the community from other nonprofits in the area and things like that. And it's this stigma campaign, right? And to think that you're going to be able to change a stigma around addiction and alcoholism by putting some posters up, is a little ridiculous to me, right? Because there has to be a fundamental change of how you view this, whether you view it as a disease or not, right? But that you view these people as suffering human beings, right? One of the things that I've talked about on a couple different episodes now is commission that went to Vancouver on harm reduction, right? That they approach people who are in active addiction for help, and 91% of them are receptive to it, right? So my question to the medical community is, where else do you get those kind of numbers? If you approach a 40-year-old guy or woman, whatever, that's obese, and say you need to exercise and lose some weight, or you're at risk of heart disease, or you have high cholesterol, what percentage of those people are gonna get active,
change their diet,
and make a fundamental change in their lifestyles? It's not 91%, right? So what's missing in that particular component? Right, that if 91% of the people that are in active addiction are receptive to it, what's the missing component? And my feeling is that it's compassion, that we're not looking. And then, one of the people at the table started talking about empathy and how a lot of people don't have the same kind of reaction because they haven't lived it, or they don't have a family member, or they've never seen it before. And my point to him was, with all due respect, empathy is very different than compassion, right?
Yes.
Empathy is an emotional thing. Compassion can be cultivated.
Yes.
And you can show compassion because compassion is just wanting to end someone's suffering.
Yeah, just as another human being. And that's some of what you see why people are getting trained, because everybody wants to help on some level. And I think another human being can help another human being on some level. But when it comes to recovery coaching, obviously there's more that's needed to help a person the way they need to be helped, and it's not just these trainings. You can't, in my opinion, you can't just train anybody and they're going to end up a coach. You know what I mean? That's
right, and I think it takes a particular type of person too.
Yes.
And that has had some recovery to show for. Also, I think that's a factor. But also at the base of that, I also have to admit that I think a big component is the person's humanity and their ability to talk about their own experience and want to help and not want to. I think, Dennis, what gets me is we basically work in a healthcare industry where the assumption is that people got into this line of work because they cared about people.
Yeah.
And you see people more and more and more and more that by all appearances don't. Right? That
can't work with people, don't know how to talk to people. Yeah, all that stuff. They're rude. They're
right.
Yes, they're short-tempered. They're
right.
Yeah, all that stuff. You see that, and you go, "Why are you
even doing this?
Why are you doing this?"
Yeah, exactly. So the coaching role, I think, and you know, I think what Julio was alluding to was that there are a lot of kind of rogue factors in this,
sure.
right?
Yep.
I saw something about recovery coaches making $150 an hour, right? We certainly don't, but those are the ones that are going out and saying, "Hey, I'm a recovery coach."
Yeah, those are the people do it private.
I can help your kid on Marblehead Neck, and
yes.
and all you got to do is pay me $150 an hour, and he'll stay sober.
Or sometimes they're not even the ones doing it. It might be the parent going, "Oh, I heard you're
right.
Can you help my kid?" And because I've seen that also. I've seen people be approached that a coach is the person knows they're, or maybe not even coaches, just in recovery, you know, and hey, my son's a mess. I got a bunch of money that I'm willing to throw around. Can you just help him?
I'll do anything I can.
Yes.
Which, depending on the person that's getting hired, is a whole different ball of wax there,
sure.
right? So, I mean, that I think is the problem. And I don't know that there's any... Mark Kennard was on one of the first episodes we did, and
yep.
he was talking about one of his first gigs was part of which was kind of determining whether or not people should enter into this field.
Oh, the late act or whatever. Yeah.
Yeah.
You were saying that.
Right.
I remember, yep.
And that they were, and you see it a lot. I see it a lot in AA meetings and stuff like that. Someone's a year and a half sober, and they go, "Oh, I know exactly what I want to do. I feel great. Right? I'm going to go take a class, and I'm going to get a degree finally, and I'm going to get my associates in addictions counseling." And by the time the 18 months is over, they're off their pink cloud. They're miserable. They're looking at how little it pays, and the degree goes towards nothing. And
yes.
And so what Kennard was talking about was that part of his role was to kind of look at people and go, "You know what, this might not be the right thing for you."
I don't think we live in a world where that would fly nowadays.
I think you're right.
And like, I don't think we live in a world where somebody's going to walk up to a mother who lost her kid and go, "You shouldn't be a recovery coach," or something like that. You know what I mean? Like, you're just, you're too vested in this, maybe, or not every month, but I don't think we live in that world where that could happen. Right? Not everyone, but people are too afraid to go, "No, you can't, you shouldn't, you can't do that." And I think that's some of what we're seeing also is why it's just whatever. Everybody, because they're allowing things to happen that, and BSAS too, because that supervisors training even, like they say it's geared for people that were already supervisors.
Right.
I can probably name 10 people that were never a supervisor.
So can I.
And that's part of the problem. That's within BSAS. That's not just this secondary training. That's them going against what they say that training is about, and that's also part.
Well, yeah. So in order to take the training, for those of you listening, in order to take this training, you already have to be a supervisor. You have to be in a supervisory role. in order to even take the class. And when you actually get into the class, you realize that half the people who are in the class are not supervisors and not actively supervising anyone. And my impression of, we're getting kind of off track, and this might be something for another show, but my impression of what that whole, what is it, three days,
Yeah,
2 phone
days,
calls,
and then you come
some
back.
webinars,
Yeah,
and it's like 5 or 6 days of stuff around that is supposed to be basically not teaching you how to supervise, which I felt that it was. It was teaching you how to supervise people, and explaining the role of the recovery coach, and some of the questions that they can answer, like the self-care question, which is fundamentally against the law, at least according to the American Disabilities Act. And they're saying, well, you have to, talk to your recovery coach about self-care. And I raised my hand and I said, well, you can be sued for that.
Yeah. How do you do that?
Yeah, exactly. How do you do that? So let's get back to the commission.
Sure.
So Janeer Hernandez, I always find these questions in particular to be kind of open-ended. I would rather, they had, I guess I hate this word, but we'll call them recoveries. They had three people who had consumers who recovery coach consumers, and typically I don't want to play all the audio, but or as I said before, I will put the entire audio up under this episode. But what I find is one of the landmines in something like this, asking recovery coaches or people in recovery to speak on any panel, is they often think they're at an AA meeting, and they need to talk about their life from DNA on up.
When it all started.
So there was some pretty long-winded conversations in there. But we had a couple of good ones, and one of the questions that Janeer asked, I'll let Janeer say it himself.
We are charged with making recommendations around recovery coaching. Is there anything that you can think of that you think is important for us to hear that hasn't been mentioned, that you experienced or that you see other people experience by way of the need for additional coaches, services, that sort of thing? Is there anything that we need to hear that you are aware of and that we're not talking about?
So pretty open-ended question.
Yes.
Anything that we need to know about that we could be doing better?
Is there anything we didn't think of? Yeah, there's a lot.
And you're asking that to 3 people who are
they weren't prepared for that, and that don't probably understand the role too much, even though they consume and they don't probably get it too much either. So
let me play one of the clips, and hopefully I get the right one.
I heard one time somebody said a ham sandwich could get approved to be a recovery coach, and I didn't give it.
I don't know what to think about that, but
I didn't give it a thought, and then I kind of was just thinking about it, and I was like, oh, that makes sense. So, anybody really could do that, right? I mean, because you guys really want people to help us, right? That's your goal, is to help, stem off some of this crap. And I get it. Do anything that works. Well, this works. And if something works, throw money at it, make it work better.
I kind of like the second part of that answer, right? It's like, this is working, right? Yeah. So you had 3 people up there that had positive experiences. At least I got, for the most part, with the coaching model.
Yeah.
And then this one particular guy, along with the ham sandwich comment, which has some history to it that we may or may not talk about, but goes back to what Julia said and to what we've been talking about, is that you can go and you can take a 5-day class and you can say that you've got a certificate, because you do. Now, that doesn't mean you're certified, right? But in a lot of people's minds and the way people translate things, certificate means I'm certified, right?
Yeah, and I liked his answer too, and as far as the if something's working, help it work better, if you can, or just sustain it in some way, or, keep it going. And obviously on some level this is working, or they see a need for it. And I when he said the ham sandwich thing, like I wish they understood where, like just hearing that and not understanding where, I was coming from when I said it, might, you just hear that and you go, oh, what the hell's he, talking about? But I think.
Well, what were you talking about?
Well, I think we've kind of got into it a little bit already, but the whole, no one's saying no to anybody. Like, we've kind of already, so you go and get trained and you can get hired anywhere. Like, it's not hard to get hired. That's evident right now. There's so many job openings. And kind of like I said, once it gets to the point where you handed in your application to be certified, you've already cleared all the hurdles so I'm wondering if, and I don't want to assume anything because I don't know, but does the person that is signing off, so obviously the person that is doing the certifications understands the training process, right? She she understands what trainings we need to take, which ones are good, not good, that type of stuff. But when she looks at an application and sees, this person's working in this setting and this, is she able to look at an application and go, this isn't adding up, you know what I mean? Or you signed off on my hours, I signed off on your hours. Like, does she understand, do they understand the role and how it's kind of supposed to work? And are they able to tell by an application that, are they able to sniff things out when they see an application that this doesn't add up? Or are they just going, all right, you did this training, did his hours, signed off, boom, now you're certified.
Are you talking about actually having the CARC?
Yeah.
Okay.
Yes, 100%. Because there are people I know that have it that have not done 5 hours, 500 hours, that were not supervised, were, don't have a job description that should pass snuff. So either they fudge stuff or, what I mean?
Right.
All that stuff. Like, so when you look at it and go, are they able to sniff that stuff out? Or is it just by the time it gets to that point, you've cleared all those hurdles? So that's what I meant by.
Yeah, I would imagine no. I would imagine that it's very easy to get someone that has a supervisor certificate,
and
that may or may not be in a supervisory role. But how do you it doesn't seem like anyone's asking for proof of that.
Especially right, they aren't even asking. So the trainers, they're not asking where the trainers work. So as far as in-service trainings, I know a few organizations that have done those, that people got, because they're not asking the trainers even where they were working.
Right.
So there's so many holes in this system that people say aren't, like, you're not supposed to do this, but how do they check it?
Well, it's kind of similar to, I may be going out on a limb here, but you had all of these rich parents that were paying for their kids' education,
sure,
right? That's recently in the news, right? They're going to Stanford and Yale and stuff and basically bribing professors and coaches and stuff to get their kids in, right? And apparently they have kids who shouldn't even be in college because they didn't even show up for high school. And now you've got people with degrees from Stanford,
yeah,
right? Who are, their understanding is that their degree is useless, and they're suing Stanford because their degree doesn't mean anything right now.
And that's what do you think
that's a fair comparison?
For every person that gets through that shouldn't, I think it cheapens what we've done.
So that would be yes, it's a fair comparison.
Absolutely. No, and that's what I'm saying. And I've said that. And so when I first made the comment at a MOAR meeting, it's exactly what I said. I said, for every ham sandwich that gets through, it cheapens it for us. It makes our job marginalized and less easier to take, less, it's so easy not to take it seriously when you look at that stuff, because it's so they're training anybody, it's just, they're treating it like it's CPR or it's the Heimlich maneuver. if that's the way it is, why don't we just all stay home, save everybody a bunch of money, and put some videos on YouTube and go, this is how you become a recovery coach. There you go. And that's how I feel it is right now. Not maybe to that extreme, but almost.
Well, we already have basically a system that if I want to take a supervision class and get a certificate that's accepted by BSAS, I have to go through AdCare and BSAS, right? BSAS is also running their own RCA, right? The Recovery Coach Academy.
Yes.
Now, CCAR also has like satellite training, right? So I can either go down to Connecticut and take it, or I can find a trainer up here to take it. Does RCA have the same kind of agreement? Because BSAS will accept CCAR training.
Correct.
Right? And they'll accept RCA training. But so if I wanted to train someone in the first 30 hours, those first 30 hours of class time that's required, right? I think there's 60 hours altogether,
60,
right?
Yeah.
So if I wanted to train, could I just apply to CCAR RCA and say I want to train, and they send me a book?
Not that I am aware. So if you're a trainer, I believe they...
So with CCAR, for example, you have to go through train the trainer.
You go down, train the trainer.
Right.
And then you can come back up here, and every time you want to run a class, you just buy the books. And you go, And you...
I
don't think you tell them who you're training or anything. You just go, oh, yeah, I need 15 books or, whatever. And you pay like $75 for that packet with the books and all that. I think that's what it is. I think that's what... I don't know exactly, but roughly. And then you charge these people whatever. And that's... So there's no...
So North Shore Community College has the two classes also, right?
Correct.
And those aren't from RCA or from CCAR. They've got their own curriculum, right? They have their own syllabus and their own...
that I don't know. I haven't looked into that, but they're approved. I would say.
Well, they're approved, and BSAS has approved them.
I don't know where they came up with the curriculum.
That's where I got my second 30 hours, right? But I mean, what's to prevent, for example, online Phoenix University from running a class for recovery coaches, right? If it's going to be approved.
Other than to be certified, you're not supposed to take any online classes. That's
well, okay.
So that's
there's that caveat. Yeah.
That's not, other than that.
Right. But that's also going back to when you basically had these piecemeal classes that were spread out all over the state, and you had to drive from one corner of Massachusetts to the other if you wanted to get your classes done in any kind of timely manner, right?
Correct.
I mean, I took one I think there was one in Plymouth, and then I took one up in Springfield, and then I went to, I don't know, I think I had actually taken about 3 or 4 of those hours before, or more than that. It probably was about 20 hours when North Shore Community offered theirs, and I just said, the hell with it, I'm paying the $500. And
I had one class to go when they started doing those 5-day. I was like,
yeah.
Thank you.
Well, and it's the same situation we're in to continue our certificate, right? In order to retain it, we have a bunch of classes that we have to take that we can't find also.
Correct, but we can't take online classes, so that's good. But we can't repeat trainings, which we kind of got to get creative in our research process too, because there's only a limited number of trainings that. Are kind of offered through BSAS for our domain anyways. You might have to go outside the recovery coach domain to find some trainings, like take a mental health ethics, if they okay it. But you can't repeat a training, so it's it becomes, you got to get creative a little bit.
Yeah, and kind of what I'd like to see would be for people who are working in hospitals and in clinical environments, when they offer something like a grand rounds or something like that, which is, we're talking about experts in the field talking about addiction and mental health and all different kinds of that BSAS would start accepting those, and that maybe there's a way to communicate with the hospital staff and allow other recovery coaches in the area to sit in on those and participate and get it. Well, I mean, here's the thing, right? Nurses and clinicians.
I don't know.
Well, because it's not talking about any particular patients, right? What grand rounds are, for example, I forget his first name now, but Dr. Suzuki at Brigham is supposedly an expert in motivational interviewing, right? And he comes and he gives talks. I sat in on a talk of his that was about prescribing opioids in the hospital for people who are addicted to opioids, Right?
So, yeah, I mean, that sounds like it would be something that you,
right. And there are CEUs and SEUs offered to
like nurses
to
or
clinicians
whatever.
and nurses
Yeah,
for that class, right? But BSAF doesn't accept it, right? I sat through a 3-hour conference on pain management, and they wouldn't accept it.
Wow.
Right now, I don't know about for continuing my certification, right? The research, but Danny Ginnivan, who's been on the show before too, has told me, and I think he looked it up, that there are a certain amount of hours for the recertification that those are allowed. They just can't be, but it's like in service. Right, so if you're going to the place that you're working at, that's giving a talk.
I don't know,
or they do allow
in-service trainings are okay for the research, but not for the cert.
So something like that for the recertification, that would be acceptable.
Yeah, if you did it at your place.
But I think it's like anything else, right? If you're requiring people to do certain things, you have to make those things available.
Yeah.
Right, you can't make them impossible to get, and at least getting the certification to begin with sort of seemed like that, right?
Yes, we definitely had to chase it a little bit, and so there are obviously pros and cons of the trainings being consolidated and kind of localized. I think it makes it easier for people to take the train, people that shouldn't be taking the trainings to take the trainings, and so that's one kind of.
Well, and there are a whole slew of things going on too, as far as coaching and what's required of coaching and how things are going to change, and documentation's a big part of that. And
sure
actually the commission talked about that, and that conversation always seems to get people a little excited.
It does,
and I think that there's a feeling on the clinical side of this that the complaints are because recovery coaches don't want to do that work, right? That this is that now it becomes work.
Yes, and
that's what the complaints are about, right? And it's almost an accusation of potential laziness. Of we've been doing this like this for years.
Yep.
We have to have this. This is part of the job, and you're just going to have to do it. And one of the things that William White had talked about extensively was just that, right? Is that once you start kind of tearing apart the role, and basically what he says in one of his papers and also in one of his talks is that we had roles in the 70s that were designed to help people that were in addiction and alcoholism, right? And that's where addictions counselors came from and things like that. And it was pretty much a role like ours. People who were in recovery were now dealing with people in recovery, and they made a whole industry around it within psychiatry and psychology and social work. And little by little, they started adding regulations and paperwork and things like that to now we're in a position
we're right back where
we started, where they've destroyed that, and now they have recovery coaches. So as luck would have it, Dr. Duckworth,
we have a clip.
Dr. Duckworth, Kenneth Duckworth, Dr. Kenneth Duckworth, I think he's a psychiatrist, right?
Sure.
And he is he's a top brass at Blue Cross Blue Shield.
I believe
he's
right? Blue Cross, yes.
Blue Cross, okay. So this is one of his questions. I have two questions from him, but this one is about the documentation, and you'll kind of you'll see where the argument is on the side of an insurance company, a clinician, and someone who is interested in how are we going to pay for this, right? Okay, so here's Dr. Kenneth Duckworth.
I heard several comments about not over-documentizing things. I don't know if that's a word.
You just made it a word.
How do you think about accountability and standards? Because the third-party payer is rooted in that. That's why I was asking about evidence. That's the root of how a third-party payer thinks about delivering charges to, let's just take Dunkin' Donuts, because everybody knows it. Dunkin' Donuts will be paying for this. You will be paying for this for your healthcare benefits for all of your employees. How do you think about how you balance accountability and kind of independence, connection?
So the whole accountability issue, right, which is how do we actually know you're doing what you're doing? Yep. My argument has always been, one, there's the proof, right? I've got this many people and I've had them for this long, and what does it matter what details I'm putting in to a person's medical records, which gets into a whole different aspect of what are we doing, what are we sharing, and what is our relationship with the person that has been referred to us, right? The recovery or the consumer. Yeah. There aren't any words that I really like. I tend to refer to them as my peeps, but that's just me. And so I do understand the concern on the part of insurance companies, right? Which Duckworth is obviously a part of. He seems to be kind of reasonable, at least the times that I've seen him on the commission. He asks some good questions. And I think the question is more like, if we're going to pay for this, how do we know what we're paying for?
Yeah.
Right? So one of the answers came from Keith Scott. And so this is what he had to say.
I mean, I would just say quickly that you can negotiate this with third party. We've done it in one situation, and I think we've had conversations about the difference between documenting hours spent with a person and documenting content of activity and content of conversations. So I think we can continue to work on this in a way that will kind of meet the needs of third party payers. And if you sort of dilute this role so much that it's no longer what it is, then it's, what are you paying for? I mean, if the sort of what's valuable about and what's special about these roles is lost in the negotiation of documentation, then is it really worth doing? Is a question I think that we ask ourselves all the time.
So really kind of taking away from the original premise of the role, right?
Yeah. So I kind of liked his answer where he said, we can keep track of how many hours we spend with somebody. Why do we have to keep track about what we're talking about, like the content? And so I work at a place where we do notes, and
so do I.
Yes, and my supervisor has, and thank God his bosses kind of understand the role a little bit, and they don't want to get us too caught up and too detailed in our notes. We just do very basic. So the only problem I can foresee is, because I haven't had to do a reauth yet with insurance. So when that time comes to reauth, what do they want? Like, that's a process I don't know yet, because I haven't been there long enough. They haven't been doing it long enough yet. But so far, to get somebody covered by insurance and what they ask for while they are being covered is not, and I think Danny says that in his response, it's not too invasive at this point that I can see. It's not too, it doesn't bog me down too much. It doesn't take up that much of my time. It's very basic, met with recovery, did wellness plans, set goals around, and then when I meet them again, that's it.
Yeah. So here's the thing, because you raise a good point, and I've heard that before too, right? So there are two aspects to that. Is one, I sit down with a person that's been referred to me, and I say, and right up front I say, listen, I'm not a clinician, I'm not part of the medical staff, I'm just me.
Yep.
Right? You and I are going to talk. We're going to figure out what you want to do, how you want to do this. I don't report back to your therapist. I don't report back, because I work in a medical setting where people have a PCP and a therapist and a social worker, yeah. And I make it
same as my place.
Yeah. Right, and I make it pretty clear that I'm not going to that I'm not an arm of theirs.
Unless
right?
Unless they want you to be.
Right. Okay. So I had a guy, and I'm thinking, okay, maybe in the notes I put that, he wants to work on meditation, or he's got some anger issues that he's working on, and I'm putting that in because that's what the insurance company wants to see. hypothetically put in the notes that, he wants to work on meditation. He's got some anger issues, blah, blah, blah. Maybe he smoked some pot last week and he's not too happy about that. Now, he's got this therapist who announces that she's leaving for another job, and he switches therapists, right? I've been talking to the guy for a year. He calls me, which is great. As you know, most people out there know that if you're dealing with someone in addiction or who is getting into recovery, one of the most important things is, at least for me in my sobriety and recovery, was communication
showing up
and being able to call and say, hey, I'm not feeling so great today. I just need someone to talk to, asking for help. So he's doing that on a regular basis. He gets a new therapist. The therapist looks through the notes and goes, I see you smoked a little pot last week. You want to talk about that? Right? Now my entire year is blown with this guy, right? He can't trust me, right? Because I promised him that I wasn't talking about the stuff that we're talking about. And now where are we? Right? That's the problem that I foresee. And the other aspect of this goes back to regulations. Just like we talked about with the ADA and supervisors not being able to ask about your self-care, or anyone in recovery, actually. If your employer knows that you're in recovery, they are not allowed to, it becomes discrimination. If they're saying, hey, are you going to meetings? Are you taking your Suboxone? It's a violation of the Americans with Disabilities Act. So under HIPAA, which regulates medical records and stuff like that, there's an extra layer added for people in addiction, which is the 42 CFR, right? Which puts you in a whole other section within medical records. So people like social workers, some doctors, anyone who's not dealing with substance use disorders cannot read those notes. So my question to the medical and clinical community is, do you want me to put details in my notes about what I'm doing with this person that you're not going to be able to read? Or do you want to know that I saw this person 3 times this week? It's none of your business what we talked about, but I saw him 3 times this week, right? So you start getting into some very interesting terrain, right? Particularly around that, because in my case, people are referred to me by social workers or by the primary care physician.
Yep.
And they've referred that person to me because they care about them. They want to see them get well. And if I'm adding notes to the medical record under 42 CFR, they have no way of knowing how that person's doing. And if they can't get in touch with me, or if I can't be reached, or if I leave, those records are essentially sealed. And should that person call and say, I can't get in touch with Richard, I think I'm in trouble, there's nothing for them to refer to. They don't know that I've seen the person 5 times or 10 times or whatever. So it gets into it starts getting very complicated. And another point that Julia made at the MOAR event was about training organizations on how to deal with,
how to support the role,
role.
Yep.
And part of that was policy change.
Sure. And so I know where I work, there are still some people that are trying to figure out how to utilize us, what exactly it is that we, like I was asked to fill out a psych social last week, and I was like, no, absolutely not.
Right.
And
we're not trained for that.
They didn't quite get it, and obviously I talked to my supervisor to make sure I was assessing that properly, and then we went to him and explained, I understand you asked me because you wanted me to help the person, but that's not my role. That's a clinical document. That's not. I don't want to know about his trauma, history, and that's not.
Right. Well, you and I have talked about that too, that we don't necessarily read other people's notes on that person, right? And I got into a bit of an uncomfortable situation because some of the social workers that were writing notes were like, "Well, why don't you read our notes?" And they were kind of like offended, right? They felt one. At first, I thought they thought I was just a moron, right? Like, why wouldn't you read my notes? I put so much into this. And
like it's some novel that
you get to know everything about this person before.
Was it good? Did you like it?
Before you talk to them, and that's part of it, right? I put a lot of work into this, into writing
and
these notes
looking at it.
in order for you to understand what this person is going through. And my point to them was, I on purpose do not read your notes, because I want them to tell me what's going on with them. Right? I don't want to look through their history of what you think it might be. As a sidebar, when I was sitting in this board meeting, people had a lot of things to say about people in addiction, right? And where I find our role to be fascinating is listening to people think that they know what this is about, right? And how it should be addressed, and not understanding things that I think to us are fundamental truths. Right? I'll give you an example. So this one person is talking about how people should be approached in the ED, and and how horrible it is that they're put in the hallway, and that they're just cast aside and they're left there for 6 hours and stuff like that.
You're talking about people that have like overdosed or something?
Yeah, people that have overdosed or have come in with they're drunk or they fell, and right, and they're immediately treated like garbage, for lack of a better term, right? And what I said to her, and I'd be interested to see if you agree with this. What I said to her is, I said, you're not doing anything to me by treating me like crap. If I'm in the ED and I'm on a stretcher, and you
I already feel like enough crap.
And you put me in the hallway, you're only confirming for me what I already know about myself.
Putting me in a hallway makes it easier for me to leave. Thank you.
Right.
That's how I would. That's how I would.
Well,
feel
yeah, exactly. Right. And it's like, oh, okay, yeah, whatever. It's like I'm used to that. If you show me some kindness and some compassion and ask me if I need something, now you're going to disarm me.
Yeah.
Right. Now I'm going to, and that the fact that we understand that, the fact that we know, and that I have yet to meet someone that's been referred to me that, for if they're crying, or if they're angry, or if they just don't know if they can stay sober or whatever, that when I say I know exactly how you feel and I'll tell you why, they know it, right? Because at a fundamental level, we know when someone's telling us the truth. I don't mean us as alcoholics and addicts. I mean human beings.
Sure.
You know at a very deep level when someone's telling you the truth or when they're BSing you, right? So the fact that they're, I don't want to say mistreating people, because they're not being mistreated, but if I've been treated like crap my entire life,
sure,
particularly when I was drinking, and I've always had a low opinion of myself. I have self-hate, and so all you're doing I say this at meetings all the time, right? If I'm walking down the street and someone says you're an a-hole, my immediate reaction isn't F you.
They must know me.
Yeah. My immediate reaction is like, wow, you're a really good judge of character. Right? We should talk about this some more, because I've been trying to figure out why, and I think you've nailed it.
Did I go to high school with you?
Yeah. So you know what I'm talking about.
Yeah, sure.
So what?
But it all ties. That's part of, and it's not just lived experience, but I mean, it is. It goes back to that. And people want to help. Like, those doctors want to help, most of them. And they don't necessarily know how to, you know what I mean? So that goes back to, like, not everybody can help in the way that needs to be helped. And that's, I mean, it's tough, like, so working in this clinical environment is, because I didn't, for the year and a half before I got to where I'm at now, working, I was in, I wasn't in a clinical environment. I was in a, I was getting referrals from anybody, no insurance involved, and it's certainly different. You know what I mean? There's no doubt about it. It's a different environment altogether.
Right, but I think, and going back to the paperwork and the policies and things like that, right? From with Julia talking about policies need to change, and then with this Keith Scott saying at the end of the day, what are you paying for, right? If this is what you're doing, I think it becomes incumbent on the part of the insurance companies.
Yeah, they can change. Yeah, sure.
Exactly.
Yeah.
In order to address this issue, which has so far killed 70,000 people.
There has to be a way to figure it out where we're not.
Right? Is not taking the same model and going, we need to fit the recovery coaches into this model. It's we need to think out of the box and find out how we're going to pay for this.
How do we keep them what they
are? Because the thing is that if they don't figure out a way to pay for it, they're going to end up paying more, right?
To borrow a line from your friends in the Socialist Party, just pay for it. That's all. Go ahead, just pay for it. That's all.
You're getting into some dangerous territory here, my friend. So what was interesting about that particular question that Dr. Duckworth had was it was also answered by an earlier person who was responding to Haner's question. So let me just play her take on this, and you'll see what I mean.
Yes.
My biggest fear is overregulation, and with a recovery coach is spending more time doing paperwork because of regulations and spending less time with their recovery because they have to fill out all these forms and being limited, saying I can only spend 15 minutes with this recovery, based on a regulation. And I worry about that. I see that happening in the future somewhere, and that concerns me.
So what I find important about that particular answer is that for once that wasn't an answer coming from a recovery coach or someone working in the field. That response was from someone who had benefited from a recovery coach.
Yes.
And who knew that person who helped her was available to her and could spend time with her and helped her get well and into recovery because they had the time to do it.
Yeah, they're available.
Right. So,
and, I can definitely. So I work with a woman who was a family partner before she came on as a recovery coach, and very similar role but different, obviously. But the billing aspect of it, that part of it was the same. And she said she saw the changes and from what they required when she first started working, as far as the insurance, what the insurance is required, to by the time she, a few years later when she was still there, it changed drastically, and they required so much more for them to, continue to bill for that service that we have people advocating for us right now not to go down that road. And they didn't have that, you know what I mean? So we have this whole commission kind of, and people advocating against us, the fidelity of the model, everybody says that, so that's obviously a good thing. We just hope they're kind of listening and they care. But that guy from Mass Health, obviously, is a big part in this because they're the only ones that are reimbursing for it right now. So it's what are they? Everyone's going to look at them when this blows up or not. When it takes off. I shouldn't say blow up because that's so. But if it keeps going, and other insurances start doing it, they're going to look at Mass Health and what kind of Mass Health does, and so whatever they're willing to.
Which is paying for it.
Yes, they are paying for it. 100%.
I mean, the guy that asked the question is from Blue Cross.
Yeah, and so everyone will look to them. This is like a pilot right now, basically, what Mass Health is doing. And if they accept, continue to accept what we're doing now, I think, which isn't a ton, but, like we've talked about, is it still too much sometimes, like the notes that we're doing and things like that? I don't.
Right, and addressing it does kind of feel like, anytime I talk about it with my supervisor or other people in the field, I'm aware that it sounds like I just don't want to write.
I don't
notes,
want to do anything. Yeah,
right.
Yep.
And I don't want to do real work. Right. That's how it comes off.
I get it.
So it's a difficult argument to have when you already go into it with a certain degree of guilt. right?
Especially when they do so much of it. That's their job.
Exactly. And at a certain point, you want to say, well, that's your problem, right? This is not how this model is built. This is not what this job's about, right?
I find myself saying that's not my role a lot, like where I'm at. And I feel similar. Like people looking at me like I don't want to do work. Like I'm not, or say even the people that I'm working with sometimes. Are they looking at me like I don't want to help them, because I'm saying, that's not necessarily what I do. I can help you do,
Right. It's a kind of a tricky role to navigate, right? Particularly because, by all appearances, and I'm not saying this to minimize the role at all, by all appearances, we're just hanging out in coffee shops talking to people, right? I mean, really, it's like, what do you do all day? Well, I met 3 people at Dunkin' Donuts.
It's like somebody to a meeting.
Exactly, right? But it's the conversation that's happening in between that stuff and during that stuff. That's the work. And I also think it has come up at some of these commission meetings also, but I think it needs to be made very clear that when you're in this role, when you're doing this kind of work and you're in recovery yourself, I think you become acutely aware of your own recovery, right, and of your own stuff.
Sure.
So To say that, I think it's going a little far to say that it's putting people in dangerous situations, which I've heard, right? I mean, I was at the supervisor training, and this one guy just kept going, well, we're dealing with people who are fragile. These are fragile people. And I'm like, if you say that one more time, I'm going to hit you with a chair, right? Because there's this impression that we're kind of fragile and easily triggered, right? And if you say the wrong thing to me, I'm going to go drink.
Yeah.
And so that has to change. That kind of attitude has to change. And what I think it is us. Well, let me just play out this thought. Yeah. Is part of our role, and part of our role in a clinical setting is also to make people aware who have been working in this field for a long time that they're in their own bubble, right? That all they're seeing is people who are relapsing, who can't stay sober, who are coming in and out all the time, right? And that, I come into this, for example, I'll use me as an example. I come into this with 12 years in recovery, right? And I'm talking to a therapist, and he goes, wow, your father died, and it's amazing you didn't drink. And I was 10 years sober at the time, right? I had the tools available to me to be okay and to get through it, right? So I think that's also part of our role, particularly working in a clinical and medical environment, is showing people what's possible, right? I saw a poster. I want to say it was the Paris airport, but I can't remember. I went to Switzerland a couple weeks ago to visit my daughter. I know that sounds really snooty.
Humble brag.
Yeah, I know. But there was a poster, and it basically had this guy in a suit and tie, and he's carrying a briefcase, and it said underneath it, "This is what a junkie looks like."
Yeah.
Right. And it's that kind of message, right? Of getting people who have been doing this, who are haggard by it, who are fed up with it, and going, I want to show you what's possible, right? I want to show you what can happen here. I want to show you where I came from and what I'm doing now. And there is always that little kind of underlying stigma. But going back to that question and to the regulation and to what Keith Scott said about it, is you can regulate this to death. You can document this to death. And then you're taking away from the original role. And I liked his response. And then what are you paying for?
Yeah.
Right?
100%. That's, hopefully they hear that. You know what I mean? Hopefully they go, we can't change it too much because then it's not going to work.
They might not. I mean, we've got a healthcare organization in Massachusetts that owns an insurance company, right? They should be the ones. They should be the ones to lay the groundwork.
Sure.
They should be the ones to. Speaking of the large healthcare organization, at that MOAR meeting, that public policy meeting, there was a mild showing by partners. A couple of women got up and talked about partners, and I don't know how you feel, Dennis, but I found the presentation to be lacking, to say the least, and I think it was a missed opportunity. This is a public policy forum. Partners as a whole.
Talk about what you're doing. If that's what it is.
Partners as a whole. Newton Wellesley, Brigham's, Mass General, Lynn Hospital, Salem Hospital, North Shore Physicians Group. There are dozens of recovery coaches working in those hospitals, in those primary care facilities, in the EDs. There are people outreaching to homeless population. There's a homeless walk-in support for people to come in on a regular basis and meet with one of the recovery coaches. There is there's a kids addiction thing where one of the recovery coaches is dealing with youths in the community. There are urgent care clinics that have recovery coaches, community-based offices that have recovery coaches. There's some in Revere. There's some in Chelsea. Yeah. There's they're all the way up to Newton and Brookline and halfway down to the Cape. From there all the way up to Raleigh. Partners Healthcare has, I want to say a dozen, but I think it's more than a dozen. They're in the ED. They are in inpatient when people come in with a secondary diagnosis. They are outreaching to homeless. They're outreaching to the youth. There is one woman who specializes in women with addiction who are pregnant, right? There's a whole clinic dedicated to that. The stuff that Partners is doing in Massachusetts, up and down the coast of Massachusetts, and almost up into New Hampshire, is phenomenal.
I didn't know that.
And you want to talk about public policy. The public policy that happens in hospitals, world famous hospitals like Mass General and Brigham's, in my opinion, has to succeed. It has to succeed. Because much like the Supreme Judicial Court in Massachusetts, the other courts in this country look to Massachusetts. They look to Massachusetts, sure, and they use it as precedent, sure, right? So you have Mass General, Brigham's, Newton Wellesley, North Shore Medical Center that are doing things. If it fails here in Massachusetts, no one's
going to bother.
Other states are going to go, why should we even try?
Yeah, because we have money, we have, we got all that stuff, the knowledge, So I agree with you.
I understand that giving a presentation is difficult. I understand that people get nervous and lose their train of thought. I was just it was disheartening that this was an opportunity for them to talk about some really big things and some important things that are going on in Massachusetts that organization is responsible for, and that I agree.
I mean, I had no clue that's how much Partners had going on.
Right, and a public policy forum would have been the optimal place to discuss that, don't you think?
That's what you're talking about. You talk like what's going on, what are we doing? What are
doing?
New programs we've implemented? Anything like that. And yeah, sure, that would have been a great opportunity. Like I know, I never heard any of that stuff. I know you guys have the clinics and the Bridge Clinic and things like that, and outpatients, but I didn't know you had all that. The kids and the all that. I mean, that kind of blew me. I didn't know that, you had such a vast, array of services for people.
Oh, it's huge.
In addiction. And, certainly a missed opportunity, to talk about that stuff. And because I hear a lot from people, consumers, if you will, that there's not enough going on. There's not enough being done about this, in response to it. And sure, there could always be more done, but there's an awful lot going on around here that they may not be aware of, and I know they weren't certainly at that MOAR meeting, but yeah, that stuff should be talked about.
Right,
what's going on?
And I know too. For example, Bridgewell on the North Shore has recovery coaches going into the ED in Lynn. They recently started with the ED in Salem. Salem Hospital is going to have its own part-time, 3 days a week, embedded recovery coach that will also do inpatient. So if someone comes in for, AFib and has alcoholism or addiction,
they'll reach out
to them. So Partners is doing a lot as far as reaching out and trying to address this. What I also find, particularly with the people that I talk to at North Shore Physicians Group and North Shore Medical Center, is that the people at the top care. they care that the place is doing a good job, whether or not people are being taken care of. And that is, I get disheartened a lot.
Well, I think that goes back to your point that people are looking at you guys, you know what I mean?
Well,
they
are.
take pride in that, I'm sure. I would if I worked there as well,
Okay, so enough on that. Enough about partners, different hospitals, documentation,
policy, and
I
procedure.
I think what's funny is I came into this and called you about one particular topic, and we ended up talking
about everything else
for most of this episode about everything else except what we had originally intended to. I don't even know if it's what we originally intended to talk about. But let me play again Dr. Duckworth and one of the other questions that he had. What I find interesting about this particular question is I hear it a lot. I've heard it at almost every commission meeting that I've been to. And, well, let's play the clip and then we'll talk about it afterwards.
I'm asked the question commonly, and I thought you would be in a better place to answer it than I would. People have said to me, what's the difference between a peer recovery coach and a sponsor? And I wanted to ask your perspective on those two areas of support.
So before we get into it, I want to play what one of the consumers, how they answered that question.
To me, the difference is the same thing as far as a sponsor strictly 12-step. A sponsor tells you what to do, and a recovery coach asks you what you want to do.
Okay, so that's an okay answer.
Okay, yes. It's okay.
The other answer I've heard is, actually she answered the question with both answers that I've heard, is that a sponsor is strictly 12-step. And she added a little bit extra that made people kind of go, "Oh, great! What a wonderful answer."
Yes, yeah.
And I'm certainly not saying that she said anything wrong.
No, but I think keeping it simple for them though too is kind of okay.
For who?
For the commission, Richard. If they don't know what a recovery coach is at this point, do you think they're well versed on what a sponsor really is? And start getting into, just.
But again, going back to one of our previous conversations, right? Isn't look? I mean, the thing is that if you look at the description, right? At least in my job description when I was hired as a recovery coach, and the description in CCAR and in RCA, and in anything that Bill White talks about and has talked about since the 1990s, is that part of the recovery coach's role is to work as an advocate for the recovery community, sure. Right? So again, it's up to us to educate them,
okay,
right? But here's the thing, right? Is that you and I both go to 12-step meetings, right? You and I also both know that a sponsor is not necessarily there to walk you through the 12 steps or to make you believe in God. Or I'm saying not necessarily. Well, you're shaking your head.
No, not shaking my head. But okay, that's at some point it becomes not that. But I think that's the soul, that's what it's supposed to be. So like,
is it?
As we talk about the fidelity, yes, I do believe that a sponsor is meant to bring you through the steps. And is it always that? No, but I think if we talk about fidelity of the model, I think that's what it was meant to be.
Fidelity to the model of AA.
Yes.
Okay.
So I think that, so if we talk about, and that question I asked the other day, the word sponsor is only in the big book once, and it was about Ebby, and he died.
Right.
So
what it actually says in the big book is find someone, a trusted friend that you can talk to.
Okay, so if we're talking about how they did it originally, they took you through the steps, boom, and there was none of this wait. So I get where you're coming from. Yes, a sponsor becomes a lot more than somebody who just takes you through the steps at some point.
Okay, and maybe my best argument for this is not to defend sponsorship.
Okay.
Right? My concern with this question is, because I tend to look at things negatively and I always think that there's an underhanded motive for this. My concern with a question like this is that it it is asked in order to determine why are we paying recovery coaches
if we're viable
when we have sponsors for free.
Yes, and that's, I think I said the same thing. Like, okay, so if I said to them, nothing, there is no difference.
Right.
Would they go, okay, let's go home? You know, like go to AA, which we've been doing for 80 years now, and it's not necessarily the solution for everything.
Right.
We all know that, or for everybody. So I wondered the same thing. Why do they keep asking this question? Like, how much weight are they putting into this question? Why do they keep asking it? Because I don't know, if they don't know what a recovery coach is at this point, I don't understand the need to find out the differences between a sponsor and a.
Let's go back to what Julia said in that clip we played. What makes you a recovery coach is that you're working or volunteering in a structured environment with a recovery coach supervisor supervising you, and that supervisor has hopefully taken the training from BSAS on how to be a recovery coach supervisor.
Sure.
Right? So you're trained, you're vetted, right? You're basically have the branding of the organization that you're working for, right? You and I are employed by two different organizations. Those organizations on their own basically accept the responsibility for what we're doing, right? So now you're out in the community representing that organization, right? They're responsible to a certain degree for training, for making sure that we're okay, for making sure that we're not, sleeping with people or taking money from them or whatever, right? There's a lot of trust that goes into that, right? I think that the question, I don't know where it comes from, and I don't know how many people have asked Duckworth, how many people have asked Duckworth about, so what's the difference between a sponsor and
It may come from the history of this role, though, because this role was always, this role, meaning recovery coaching, was supposed to be a volunteer thing originally. And we weren't reimbursed. We weren't working in clinics and healthcare settings, clinical settings, and dealing with insurances and, ethics inside, where we work and things like that. So the role was initially a volunteer role. And I think that's why it would maybe be so easy to associate it with a sponsor. And maybe that's some of it's carried on still, because obviously the obvious differences in what we do, and there are some obvious similarities in it. And it's exactly, how many people are really asking him? I don't know his story, but I can only assume he's not in recovery, because I think he, would pipe up and maybe say that. But how many people are really asking him, well, what's the difference? I don't, maybe.
Yeah, you think he's at a cocktail party and people are going, hey, Ken, you know what? I've been meaning to ask you.
I don't know if he's talking about other clinicians, like they're trying to figure it out. Or something. I don't. Yes.
My speculation is that this is a question that Charlie Baker had.
I have heard.
And so it's getting asked because Charlie Baker asked it.
Yeah, and I think I have heard that he did ask that to somebody, and it's kind of trickled down. I don't know so much to the commission, but I know it, that's how I heard about it, first. It was, so, yes, on some level, people are asking that question, but I don't know. I think there's obvious differences that.
Well, but here's the thing, and I mean, and some of the people that are listening know that I wrote a letter to the commission about this, right? And I have several examples of this, and I think what makes a huge difference, right, is because a lot of the stuff that we do is very similar to what a sponsor does.
Sure.
And I don't think that's a bad answer.
It's not.
Right? Because it's peer support, right?
Yes.
Just like sponsorship is. However, because I work for an organization, one, I'm paid. Two, I'm held to the organization's ethical standards along with their policies and procedures. And I think more importantly, I have all of the resources of that organization available to me, right? So I have access to social workers. I have access to primary care physicians. I have access to a SUDS clinic. I have access to, if someone is referred to me by a social worker that has an opioid problem, and
the social worker has an opioid problem?
Yeah. Did I say that?
No, but I heard that.
No, you heard that? So a social worker refers someone to me, and that person, the person who was referred to me, has an opioid problem, right? I can sit down with them and say, do you maybe want to try Suboxone? Do you want to, do you want to go inpatient? And if I'm sitting down and trying to find a detox, the social worker is helping me call detoxes and find detoxes, or food stamps, or housing, or whatever, or getting someone on insurance, changing their insurance and getting them a primary care physician. And I can go into their chart, put in an order for them to see our doctor who specializes in medically assisted treatment, right? A sponsor can't do that, right? I think what's frustrating is that nobody's answering the question in that way. And that's the answer. I'm not saying it's the answer because that's what I thought of or that's what we've been talking about, but nobody is talking about that because the recovery coach is working for an organization, that organization is available to the recovery coach and to the recovery.
Okay, but not every recovery coach is working in an organization. So
I agree with that, right? But you and I, for example, work in an organization in which we have the resources of that organization available to us, right?
Yes,
and
we
because
do, yes.
and also because we're recovery coaches, we also know other recovery coaches who may not be working in that environment, right? But we're available to them.
Oh, absolutely, 100%.
Right? I get calls from other recovery coaches that say, "Hey, I'm looking." I got a call from someone over at Healthy Streets the other day.
Yeah.
I need a doctor for someone that is LGBTQ friendly, and can you help me with that?
Well, that's part of that's our job, helping them navigate the recovery system.
But that's what I'm saying,
yes.
right? So the fact that we have our own network,
yes.
the fact that we have our own language, the fact that we have our own resources, right? If I want someone that doesn't want to quit, doesn't want medically assisted treatment, isn't ready to go into recovery, I know that I can call Healthy Streets, and I know two people that I can call personally on harm reduction on their cell phones, and have them sitting down with this person and talking to them within 24 hours.
Yeah, absolutely.
Right? So you're not going to find that in a sponsor, and that's not to minimize. I mean,
I know. Yes, I
get it.
Yes.
Right? You're going to find some sponsors that have those resources available to them, but in general.
And a sponsor would probably try to talk you out of that. They go, "Oh, you're taking your will back," or something like that,
right? Or whatever, right? Yes. So there, I think that question can be answered in a more detailed way, and also I think that probably the people who are asking it need to understand that a sponsor isn't necessarily what they saw on Nurse Jackie. Or on some HBO special about AA meetings.
Yeah, they were at an AA meeting for 5 minutes.
And 12-step, right?
Yes.
Because now they think they understand what 12-step programs are all about.
Yeah, and I mean, I think it's a tough question to be answered in that setting because you're not going to give somebody the amount of time they probably need to answer it like the way it probably should be answered. You know what I mean? You're going to get an answer like that woman gave, which, like we said, it's not a terrible answer. She wasn't ready for it's not her.
They're given 4 minutes.
Yeah, that's what I mean. So,
my letter's about a page and a quarter. I could read that in 4 minutes.
Yeah, I understand.
And I don't even have to read the whole thing.
But how long did it take you to write it?
I don't know, an hour.
Okay, so there you go.
Yeah. Well, but now I have it. If I'm asked that question, I know how to answer it. Yeah. Maybe I should be on the panel.
I think there's a lot of people
probably a lot of people who don't want that.
Yeah.
So listen, we talked for a long time, believe it or not. Well, yeah, okay. As usual. Yeah, I like that. Okay. Do you have anything else you'd like to talk about, or should we wrap this up?
I think we're good.
Probably go enjoy the rest of your Saturday
That's all right.
now that I've completely.
Happy to be here.